Thanks, Ann. Thanks, Rishi and Ann, for letting me talk. So, as Ann said, I'm Amber Shada. I'm an assistant professor at the Department of Surgery at University of Wisconsin. I'm going to talk to you today about why we can avoid high-resolution manometry in paraesophageal hernia repair. This is my main disclosure, is that I run a motility lab. So I really like manometry. I do it all the time. I get paid to do it. So I think I'm biased towards it. But I'll tell you why I still don't think it's routinely needed, okay? And then these are my itemized things I get paid for that aren't directly surgery related. So today I'm going to talk about why we can avoid preoperative high-resolution manometry, what scenarios, and then how to use manometry if your patient came to you and they already had it, and then my own algorithm, and I'll give you a patient case. These are the main two reasons that we do high-resolution manometry. So identifying major motility disorders, right? This is the board scenario of someone who you accidentally wrap who has achalasia, right? And the second is to tailor your surgical approach, which is debatable. If you were at yesterday's physiology session, we had some lively discussion around whether that matters or not. And here's some other maybe softer reasons. So you could use high-resolution manometry to support a diagnosis of GERD. It actually does a really good job of finding small hiatal hernias. You can find another cause for a patient's symptoms, if they come in especially with dysphagia or atypical symptoms. Establish a baseline manometry in someone whose esophagus physiology maybe seems questionable to you, and then explain ongoing symptoms, maybe after a treatment that you provide a patient. And then always, if a patient comes in with problems post-op and dysphagia, a lot of us are always kicking ourselves wishing we had a manometry, right? We knew what things were like before we did surgery on that patient. So this is a consensus group that was published in JACS almost a decade ago now, looking at whether, what preoperative workup is required. And I highlighted the first sentence of the conclusion, right? Currently, upper endoscopy, barium esophagram, pH testing, and manometry are required for preoperative workup of anti-reflux surgery, right? So that's sort of the way we think. But here's what I really think, right? Paraesophageal hernia repair is not the same as reflux surgery. It's diaphragm surgery, it's hernia surgery. Reflux surgery is valve surgery. They go together sometimes, right, but not always. This is a study by Don Lowe's group that looked at high-resolution manometry findings after repair. So 200 patients, all of them had manometry, all of them had a paraesophageal hernia repair, many of which were open. So maybe not pertinent to our own practice patterns, but a significant number of them had disorders of peristalsis. You can see them listed here. Where's my little, I don't have a pointer. Anyway, among the disorders of peristalsis, EGJ outflow, so if you were there yesterday, you know that maybe that's a questionable disorder at all, because these are Chicago 3, not 4. And then major and minor disorders. And interestingly, you can see that the baseline dysphagia rate, 56 versus 67%, was the same in normal versus abnormal mano groups. And then the post-op symptomatic dysphagia rate was the same and was very low. So these patients do well, even if they don't have manometry. Here's another study from Dr. Perry at Ohio State, who looked at patients, a group of 125 patients. Now, a portion of them did not have any manometry and a portion of them did. And basically, no difference, again, in baseline dysphagia rates, and then no difference in post-op dysphagia rates or need for endoscopy and dilation. So this led me to believe that maybe manometry isn't necessary, right? But here's the groups that aren't included in those studies. The patient on the left has aperistaltic esophagus, normal IRP, so it's not achalasia, but they don't have any body function, right? And the person on the right has type 2 achalasia, so you obviously don't want to miss that. But you're probably not going to miss that if you do an esophagram, right? A correct, properly performed esophagram can exclude a major motility disorder. Lipham's group showed that. I think this was presented at SAGES 4 years ago. This is a great protocol. You should take this paper, you should bring it, read it, and then look at the protocol which is attached to the paper. It gives you a great way to do a thorough esophagram workup for a patient. Unfortunately, I hope you don't have the same experience as me. I brought this to my own radiologist. I was like, look at this great protocol. I'm going to try to get rid of manometry. And they're like, we're not doing that. So Your mileage may vary, but try it. And you may do less manometry as a result. This is a classic study looking at outcomes after paraesophageal hernia repair, and from the Oregon group. And basically, the takeaway from this was, it's hard to do manometry on patients with a big hernia. 41% of patients, they said they couldn't interpret, they couldn't use the results of the manometry. Either the patient couldn't tolerate the probe, you couldn't get the probe past the diaphragm. That can be really challenging. It's even challenging to get an endoscope past the diaphragm sometimes for a big hernia. And then the third one's interesting, right? Spurious results from esophageal compression, meaning you can't even trust what you're seeing for outflow. So that's a huge percentage of time that manometry might not even be reliable. But it does tell us some things. So these are the main three things to look at, right? EGJ contractility, that's your LES pressure and relaxation, the bottom line along that high-resolution manometry graph. The motility of the body, right? Sometimes even if I can't get the catheter past the LES or past the diaphragm, at least I know there's peristaltic activity in the esophagus, which can be helpful. And then bolus transit. So where do things hang up during swallow? Do they hang up at the diaphragm? Do they hang up high in the esophagus? That can be helpful information if you do have the manometry study in front of you. Here's a manometry graph on the right. Well, the left shows a normal mano. The right shows a hiatal hernia. So you can see there's two pressure bands, right? You see the LES pressure band, always where the wave stops, there's the LES, and then there's a bottom pressure band, that's the diaphragm. This patient has an axial hernia. It gives you at least one dimension of that hernia, right? You know exactly how far the LES is above the diaphragm, at least in this supine swallow. And then Chicago 3 started to give us a little bit more info about esophagogastric junction morphology. So this is a type 1 on the left. This is a zoom-in close-up of the LES. So you see the pressure tracing, you see the inspiration-expiration change, and then you see the respiratory inversion point. That's the point at which your pressurization is positive in your belly, negative in your chest, so it's where that pressure flips, right? And you can see on the right that with a type 2 morphology, you have a slight separation between that lower esophageal sphincter and the diaphragm. So this gives you some information. These two are actual hernia LESs. So on the left, you have, they're both significant sized hernias, right? You can see the LES pressure tracing, you can see the diaphragm. It's better on the left. The one on the right is the lowest, sort of, you can see the variation, but it's subtle. The reason it's subtle is because the respiratory inversion point is different. So on the left, the respiratory inversion point is low. It's actually at the diaphragm where, you know, people who are trained to read radiology, yeah, that's where you find it, right? But on the right, it's above. It's above the diaphragm, it's above the LES. That hernia is pressurized, okay? So why does that matter? Well, it gives you a little clue as to what things look like in there. So probably on the left, you've got a big sliding type hernia. Probably on the right, you've got something that's more of a paraesophageal component to your hernia with a pressurization of that sac. And why that matters is maybe it has to do with what symptoms predominate for that patient. So someone with a pressure, traditional respiratory inversion point that's at the diaphragm might suffer more from reflux. They've got their pressure changed at the diaphragm. Someone who's got pressurization of their hernia may have more dysphagia. Here's a patient case I wanted to tell you about, not because he represents a routine case, but it's just, you know, someone that I'm glad in retrospect I didn't exclude manometry as part of my workup. So it's a 70-year-old male who came to the office with vomiting and chest pain, and he had actually had multiple aspiration episodes, but he had kind of a funny autoimmune encephalitis and had some cognitive impairment, though his swallow up here was normal. We had checked that out. So we were assuming he was aspirating based on reflux and backflow. And you can see, you can see pictures of his endoscopy. I can't backtrack, that's okay. Oh, there we go. Where you can see a pretty tight curl opening, but then a pretty significant sized hernia, that upper right picture, you're up in the hernia. So it's not subtle. And on CT, you can see that he's got a sizable hiatal hernia. So most people would stop there and would say, okay, I'm gonna just repair his hernia, which isn't unreasonable. But he had an esophagram. I do esophagams routinely, and thankfully my radiologist put in this little blurb saying 5 minutes after his last sip, here's this column of barium. So I said, that's funny, right? Got him a manometry. He's got type 2 achalasia. So he got a paraesophageal hernia repair and a Heller. So routine preoperative manometry, just to scoot back to our original point, just say no, right? Because all you need it for is to identify major motility disorders, and why do you need to do that? You're gonna do barium esophagram. But you're gonna say, oh, I need to tailor my surgical approach. You guys know toupees are becoming more and more commonly done, right? I don't think there's many people in this room who are gonna do Nissen. There are some, but there's also good data. That Perry study had an almost universal 100% Nissen rate. It wasn't 100, but it was close. And he had barely any dysphagia. Nissen's fine too. And maybe you wanna add preoperative manometry to your workup if your patient has an abnormal esophagram or discordance between their symptoms and their diagnosis, which is paraesophageal hernia. So on the left here is my workup, right? I do endoscopy on everyone, esophagram, and then a CT is selective for me. But you can avoid routine pre-op manometry. But it can also, if it's done, it can also tell you some interesting things. Thank you.